आजकाल सा चीज ना एकदम अलग अलग
Uh, Good afternoon and a very warm welcome to today's NITRD-CTD-NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Sir, Dr. R.P. Joshi, and his team, directors and team from NIIT, NTI, STOs, directors of STDCs, and faculty of medical colleges, DTOs, medical officers, and all the participants who are attending today's clinic. Introducing the faculty from NITRD, I am Dr. Saroj Meena, pulmonologist at NITRD. On my right is Dr. Rupak Singla sir, consultant in the Department of Tuberculosis and Respiratory Diseases. Now I request our director, ma'am, Dr. Sangeeta Sharma, to give her introductory remarks. Over to you, ma'am.
So, welcome one and all to this difficult to treat clinic. As has been the practice, this time again our institute is taking the lead, and I welcome each one of you to who has logged in for a fruitful and enduring experience. Over to you.
Thank you, ma'am. Now I request our DDG sir, Dr. R.P. Joshi sir, to give his address. Sir, please.
Thank you, madam. Good afternoon, all. Namaste. It is very nice to see that Dr. Singla, Madam Singla, and all the NITRD team leading the way for this difficult to treat clinic. So, on behalf of Central TB Division, I congratulate each one of you and all the participants for actively participating and supporting this initiative. And I also take this opportunity to thank the faculty who are going to present on CNS TB today. So this is one of the very important initiatives which is helping all of us to learn about the nuances of different aspects of tuberculosis. Tuberculosis has got so many different ways of presentation and different challenges that all the experts who have joined here, Dr. Salil Bhargava and many others who are joined and going to lead us and help us to come out of this difficult part. It is a very, very important initiative and one of the well-sustained initiatives of NITRD. So I thank each one of you and looking forward to learning from this clinic. Thank you. Over to you, madam.
Thank you so much. Sir. Thank you so much for your encouraging words, sir. So now we know that moving on today's case presentation, in like we every state we take on rotation basis. So which gives an opportunity to learn from their experiences. Today's session is from the state of Madhya Pradesh. Dr. Saurabh Jain, who is an assistant professor in the Department of Respiratory Medicine, Government Medical College, Bhopal, along with Dr. Ketan Jha, who is a senior resident with him, have worked up the case. The DRT today's state expert for the session will be Dr. Alkesh Khurana. He is a professor in HOD, Department of Pulmonary Medicine, AIMS, Bhopal. The national expert for the day is Dr. Salil Bhargav, Dean, Government Medical College, Bhopal. Now I request Dr. Ketan Jha to please start with the case presentation. Over to you, Dr. Ketan.
Good afternoon, everyone. This is Dr. Saurabh Jain from Gandhi Medical College, Bhopal. So we will be presenting this difficult to TB cases. This is a long case actually. The patient has been suffering from last 4 years. So over to Dr. Ketan for the case.
Good afternoon, everyone. So I am continuing with the case now. The case is a 25-year-old female resident of Shaktinagar, Panchvati, Bhopal. She presented to a tertiary care hospital in April 2023 with complaints of fever, cough, decreased loss of appetite, and loss of weight. Along with that, in the month of April, she presented with the complaints of uprolling of eye, irritable behavior, headache and vomiting, along with backache, memory loss, loss of consciousness, and history of multiple episodes of seizure. She also presented with history of delirium at the time of admission, following which a lumbar puncture was done on 30th of April of 2020. The reports of CSF analysis are shown on the screen. It is clear with low glucose, low protein, and normal cell count. CSF CBNAT was not done at the time of chest. Here are the two chest X-rays that are shown in of the patient in the year of 2020. First one is from February 2020, while the second one is from May 2020. Both first X-ray is on the left side, which is AP view of the patient, while the second X-ray is of the right side, that is the PA view. More so, both of the in both of the X-rays, the lung fields are normal, but there is a slight parahilar shadowing is present on the right side. Apart from that, no other workup was done for the chest complaints. At the time, in the month of May 2020, she was discharged with a diagnosis of tubercular meningitis, though no records are available for the same to state any other findings. ATT was started for this patient of a fixed drug combination of 3 tablets per day according to weight, which was 45 kgs. Later in June, she presented to another tertiary care hospital with an episode of seizure, which was focal, and it was on 5th June 2020, for which she was admitted in the tertiary care hospital. All the routine workups came out to be normal, but MRI was done in June, which was suggestive of multiple ring enhancing and tightly nodular regions in cerebellar and cerebral parenchyma, along with enhancement of leptomeninges and slight dilatation of bilateral, lateral, and third, fourth ventricles, which was suggestive of tubercular meningitis along with multiple tuberculosis. Patient was already on ATT, and she was also started on anti-epileptics. After, at the time of discharge, patient was diagnosed as a tubercular meningitis with focal seizure with no neurological deficit, and she developed ATT-induced hepatitis at the time when she presented to that hospital, for which modified ATT was started, which was ethambutol, levofloxacin, and injection amikacin. This modified ATT was given for 7 days, which is shown in the next slide. Along with this modified ATT, tablet dexamethasone of 8 mg BD was given, along with levetiracetam 750 mg TDS, and clonazepam was given as SOS basis. After a week of modified ATT, the review LFT was done, which came back to be normal, and patient was restarted on HRZT regimen, that is category 1 regimen, with 3 tablets per day on 20th of July 2020. Leoflox and amikacin was stopped, and linezolid was continued. Linezolid was started as 600 mg BD along with dexamethasone, which was reduced from 8 mg BD to 8 mg OD. Anti-epileptics were given to control the seizures, and it was previously given as levetiracetam alone, but now has given as triple drug combination of levetiracetam, epitoin, and clobazam. In August, patient again reviewed after a month. She was symptomatically well controlled, and patient was continued on category 1 drug along with linezolid, that was 600 mg BD, and dexamethasone 4 mg BD, which is equivalent to 8 mg OD that was previously given. Same anti-epileptics were again continued. Then in September, patient again presented with complaints of nausea and vomiting from past 3 days, and her LFT was deranged to 3 times of the upper limit. So FDC was fixed dose combination of category 1 drug was stopped, and she was started on tablet ethambutol and injection streptomycin, along with linezolid, which is being continued, and antiepileptics, which are being continued along with steroids. Following a week of modified ATT, her LFT again came back to be normal, and she was again restarted on category 1 drugs. In November 2020, patient just came for a review visit, and same all medications were going on. But patient's linezolid treatment was already been given for 5 months, which was later changed to moxifloxacin, which was 400 mg OD. Then in January 2020, patient presented with complaints of blurring of vision since 1 month, and she was weighted at 64 kgs at that time. Initially, she was started at 45 kgs at the time of starting of treatment. For this thing, prophylactically, ethambutol has been stopped at that time, and isoniazid, rifampicin, and pyrazinamide were given, along with levetiracetam, clobazam, epitoin, and dexamethasone tablet. Pyridoxine at the dose of 20 mg OD was added to the treatment. She was then reviewed to an ophthalmologist for the same reasons. After thorough workup, it was said that the blurring of vision is not associated as a side effect of anti-tubercular drug, but was because of a local infection entity which was resolved after some topical ointment. Ethambutol, which was stopped for 5 days, was again continued, and category 1 drug was followed for the same. In February 2021, she again presented as a regular follow-up visit, and in this visit, category 1 drug were still carried on along with anti-epileptics and pyridoxine, but dexamethasone tablet was later tapered off, and it was discontinued by the end of February 2021. This is one MRI. This is one CT film of the patient of 2020, year 2020 in around June, but no reports are available for this. Here it is suggestive of multiple hyperdense areas present in bilateral cerebellar parenchyma, which was suggestive of tuberculoma with a calcified lesion. Serial MRI report were done and are being stated here, along with few of the clinically relevant findings that are there for this patient in the course of duration of their treatment. In MRI of June 2020, there were multiple tiny nodular ring enhancing lesions were scattered both cerebral and cerebellar parenchyma, along with enhancement of leptomeninges and mild dilatation of bilateral lateral and third fourth ventricle, which was suggestive of TBM with multiple tuberculoma. Then in April 2022, she again had a follow-up MRI, which was suggestive of the same ring enhancing lesion, along with mild edema, and enhancement of leptomeninges was also noted, which was causing an obstructive hydrocephalus. Then in May 2022, a repeat MRI compared to previous MRI was again done, which suggested a slight increase in hydrocephalus and an organizing exudate in the CSF along the basal systems, but the rest of the other findings were resolving in that time. Then MRI November 2022 was there, which shows no significant change, and following which patient's clinical improvement was very significant with no active complaints. So antitubercular therapy was then stopped at that time. By the time of November 2022, patient had already taken 2 years and 6 months of antitubercular therapy, and MRI brain was suggestive of no significant change from in the morphology and other features of hydrocephalus from the previous MRI. So patient's ATT was stopped, and she was continued on anti-epileptics, that is levetiracetam 750 mg BD, clobazam 10 mg HS, and epitoin 300 mg HS. Then again in July 2023, patient went for a regular routine checkup in neuromedicine department. There was no active complaints of fever, headache, blurring of vision. Just she went for a routine checkup of her anti-epileptic treatment. But no exact documents are available, but the neurosurgery resident reviewed that same patient. As per the patient, an MRI was done, but no records are available. And patient was again started on ATT on 12th of July 2020, according to weight, which was 89 kg and had 6 tablets per day. Moxifloxacin for 400 mg OD was also given along with that, but no document for why it was started has been stated. In January 2024, there is a mild increase in previously conglomerated regions in the supracellular system, along with bilateral temporal lobes area. Rest of the lesion were essentially unchanged, and no other changes were seen in the degree of hydrocephalus. Then in April 2024, again the patient was advice for an MRI, which was compared to the scan of January 2024, and no significant changes were seen. There is no symptom of any active lesion or disease which was present in the patient since July 2023. By the time the second time the ATT was started. Here are a few of the MRI films of April 2024. On the left, the first film is a T1 weighted image, while the rest of the two films, the second and the third one, are the T2 weighted images. You can see a few hypodense areas in the basal cistern area of the cerebrum, which was suggestive of granulomatous lesion, query tuberculoma, and there is enlargement of bilateral lateral ventricles, which was not bilaterally symmetrical and was suggestive of hydrocephalus. There is a serial comparison of MRIs, all which were done from June 2022 to April 2024. And in January 2024 and April 2024, there is no significant change in the parenchymal lesion which were seen, or along with the degree of hydrocephalus that was seen on the MRI. This is a summary of after what happened in July 2023. There was no active complaints. She came for a regular checkup for her anti-epileptic medication and seizure to a neuromedicine OPD. She was there started on ATT at 6 tablets per day along with moxifloxacin, which is being continued till now, along with the anti-epileptics, which is already going on. She has never been shifted to continuation phase in all her course of treatment, even on the first part or on the second part. Later, 1 month back, there is a brain biopsy done, which was suggestive of poorly defined granuloma, and CB0 was a suggestive of no MTB detection. Culture reports are updated for the same. Here is a complete crux of the drugs that is being given, along with the duration for what it was given. So first time antitubercular therapy was given at a fixed dose combination from May 2022 to November 2020, May 2020 to November 2022. Then ATT was again continued from July till now. Linezolid has been given 600 mg BD from July to November 2020, followed which moxifloxacin was given for 2 months, November 2020 to January 2021. And now again in the second part of ATT, moxifloxacin is continuously going on from past 9 months. Dexamethasone has been tapered off slowly, initially 8 mg BD, followed by 8 mg OD and 4 mg OD, which was completely tapered off in the month of February 2022. Pyridoxine has been continuously going on at 20 mg OD. Tablet levetiracetam, epetoin, and clobazam are being given as anti-epileptics, and instead these three medications are still being continued on. Few of the case problems that are being stated here are there is no change of antitubercular therapy from intensive to continuous phase in all of her treatment. Restarting of ATT without correlating clinically was a very big defect. It was restarted on radiological basis. For that, documents are also not available, and she does not had any other symptom at the time of July 2023. Anti-epileptic doses like levetiracetam was not adequately maintained. Levetiracetam is generally given as a BD dose, and it is either given as it should either be given as 500 mg BD or 1 gram BD, but 750 mg TDS was given for this patient. Wrong treatment protocols are being used, like second line drugs are being given, like linezolid or moxifloxacin, where linezolid's dose is also not adequate for TB. That is 600 mg OD should be given, but here 600 BD is given, and why it was given is also not clear. Then at the time of ATT-induced hepatitis, fewer injectables were also given, which were continued for 1 week at both of the incidences, then later on discontinued, which can also be detrimental. Then at the time when she was at the time when she was having focal seizures along with modified ATT for ATT-induced hepatitis on the first occasion, levofloxacin was started for the patient, and levofloxacin has a potential of seizure in its own. Then definitive and appropriate approach of diagnosing the disease has been delayed or not being used, and which is also a bad, which is also a thing that is to be seen in this case. She presented to us just 10 days back with all this history, which was given on different hospitals. Now our plan is to trace the Mycobacterium TB culture report of the biopsy specimen that is being sent already. And we have planned to give MR spectroscopy to this patient so that we can further evaluate whether the disease is active or not, or there are any other things that can correlate to the finding of the new MR spectroscopy. Thank you.
Thank you, Dr. Ketan, for the excellent case presentation. Just to summarize the case for all those who have joined late, this is a case of clinical radiological diagnosis case of CNS tuberculosis. Started in April 2020, the patient was diagnosed on the basis of clinical features and radiological features as CNS TB and started on first-line ATT drugs. After 1 month of start of ATT, patient developed seizures for which patient was admitted, and at that time MRI brain was done, which shows multiple tuberculoma and features of tubercular meningitis. Patient was given anti-epileptic drugs along with first-line ATT drugs. But after a month, patient developed hepatitis, and patient ATT was modified to SC-Levo along with dexamethasone and anti-epileptic drugs. With the start, but within a week, the LFTs get normalized, and patient was switched back to the 4-FDC tablet along with linezolid. It was added. The reason is not known why the linezolid was added at that time. Patient was better in the month of August 2020. But a month later, the patient again developed nausea and vomiting, and the LFTs was done, which were again delays. ATT was stopped, modified ATT was given, and LFTs got normal and then restarted again on ATT. While in November 2020, the patient was doing well, and at that time, linezolid was changed to moxifloxacin. The reason is not known. In January, again, patient presented with complaints of blurring of vision. So ethambutol was holded. Author opinion was taken. Everything was normal. It was not associated to the ATT. So ethambutol was again restarted. So for next 2 months, patient remained asymptomatic and she was totally doing well. While in April 2022, patient again presented for routine follow-up where MRI was done, which shows hydrocalculus, which was increased in size. Till November 2022, no change was there from April to November 2022. So ATT was stopped because patient has taken a good almost 2 years of ATT. So ATT was stopped in November. Patient went back in July. Again, the patient presented to some other hospital and started on ATT on the basis of the clinical features and the MRI brain. At that time, for FDC along with moxifloxacin was started. Patient was reviewed again in January 2024. There was no change, no improvement seen in the MRI brain, while there was increase in lesion was seen. In April also 2024, there was no change, and when the patient was presented to the current treating doctors, at that time, 1 month back, they have done CBNet also, which came out to be MTB not directed. Culture is awaited. So this is a simple case with lots of complication and a big question mark on the diagnosis. I would like to call Dr. Saurabh Jain, who is a state expert for today's. I would like to call Dr. Alkesh Khurana, who is a state expert for today's case, to give his comments.
Yes, thank you, madam. Thank you for having me here. This is a very, very not a good here case, I would say that way. But we all as clinicians or paraclinicians who have been dealing with tuberculosis and for various time frames in our lives, this is like it could not be more wrong as happened in this case. If I enlist the things, go through the summary which you have just mentioned here, and I think I can write it down at least 10 mistakes to be on the minimum side which have happened in this case. This is very disturbing to know that we, on one hand, we are doing so much, all of you are contributing so much in TB elimination, and everything is being done at so many levels in the government. And we are having here discussing a case which is not a diagnostic dilemma. Rather, it is more than 10 mistakes have happened in one case. And another fact is that as per the history, this is not being done by a quack or an unqualified person. Apparently, this patient has been going through in a hospital setting, some kind of a tertiary care hospital setting, and has been seen by a specialist. I hope it was not a pulmonologist or a physician, but this is very unfortunate that this all has happened. The government has taken so many steps in the recent past to curb these kind of malpractices, I would say. I have to use this word malpractices here. And over-the-counter sale of first-line anti-tubercular drugs has been controlled to a huge extent in everywhere. But you cannot control the over-the-counter use of the second-line ATT drugs for obvious reasons, like linezolid and quinolones and all. For their obvious extrapulmonary indications, we cannot curb the sale of those drugs so as to avoid misuse of those drugs. So it all comes down to that rather than reaching out to the public at large, which is of course a component of the TB elimination program, we still have a long way to go ahead and reach out to our own colleagues in different fraternity and different branches so as to make them aware what is right, what is wrong, and at least please refer the patients to us or any of your colleagues who are practicing tuberculosis and pulmonologists or physicians at right point of time. That is the one thing which comes to my mind, and that has to be, we have to take into confidence our own colleagues first, rather than or alongside reaching out to the public in awareness programs and all that stuff. That's what I can say. Otherwise, if you start discussing, which of course I think which will happen now in the subsequent few minutes about the scientific component of this case, but there are n number of points which could have been corrected at various points of time in the course of 3 to 4 years in this patient. So Dr. Salil Bhargav, sir, would you like to say something on this part?
Will be your suggestion on this case as of at present? Like we have seen the case.
It could have been, the regime has been so simplified now. It could have been a standard first-line anti-tubercular drug therapy in a standard dosage that should have been given, and the patient should have been followed up as per the national protocol guidelines. The treatment was never started in a proper way. It was always underdosed. So the complications started and then kept on increasing. And even if at the point, if you have a patient, just like this patient who has a tubercular meningitis, has an extensive disease, if I could say, and if the patient is not responding, then there are other measures that you have to go for a tissue biopsy. It was difficult in this case for sure, but the next approach in the algorithm only comes if the patient is non-responsive. Non-responsive definition comes only if the patient has been given adequate drugs for adequate time, and only then you assess the non-response, and only then you go ahead. This was never done from the very beginning in this case. So that is the first thing to be said and addressed in this case. We have anti-tubercular drugs like H and Z, which are well known having a good CNS penetration. That is why the guidelines have been changed. We have come out of streptomycin and come out of the first-line anti-tubercular drugs for even TBM. And appropriate drugs in appropriate dosage could very well have taken care of this thing, along with obviously steroids, which were indicated in this case because of TBM.
So very true. But now we have seen all the mismanagement in this case, and we have to move forward with it. And can I take your opinion for how to go ahead with this case now? Till we wait for the immediate culture report to come, though CBNet is negative as of now, MTB is not detected. So
this could, in all probability, now probably would have end up in some kind of drug resistance, which is very likely possible now after 3 to 4 years. So, but in any ways, the cultures or midget are also not very far away. If the patient is clinically and hemodynamically stable, you could still wait for a couple of weeks or 3 to 4 weeks for having some culture report in hand, get your treatment individualized, and then only go ahead. I would not recommend going on a straight away shorter or a longer regimen in this case, as per whatever eligibility criteria are. If the patient is clinically and hemodynamically stable, better wait for the reports only, and then this would have apparently, this would require an individualized regime. I can presume that this patient must have developed some kind of drug resistance by now, the kind of regime this patient has. So it is better to wait, get the culture sensitivity reports in your hand, and then individualize the treatment as per protocol. That would be my best approach at this point of time, rather than empirically starting anything, if the patient can tolerate some time.
Very true, sir. Can we think of an alternate diagnosis also? It may not be tuberculosis, maybe other granulomatous diseases which present as granuloma. Should we think in that direction too, sir?
I would rather say, madam, it is unlikely. Normally, differential diagnosis, you keep it as malignancy or some things like that. These things usually would not have lasted for 3 to 4 years. If it would have been malignancy, it would have, the patient would have succumbed far earlier than this point of time. And vasculitic kind of a picture would have responded partially to steroids, but there were no other clinical systemic symptoms involved here. So there was, I would not like to keep it as a CTD kind of a possibility here, because there were no features apart from what we have discussed. A CTD kind of features were not discussed anywhere in the case. So I would not like to have any other important differential diagnosis here.
Okay, thank you, sir. It's open to the house now. If any questions, the DTOs, the professors from the medical colleges, and all those who are participating in this case discussion, you have any questions regarding this case or any advice or any suggestions further?
Excuse me, ma'am.
Good afternoon. Good
Sir,
afternoon.
we'll come to you.
Okay. This is Dr. Indranath Rai. This is Dr. Indranath Rai from West Bengal, STDC IRL.
Yes, sir. Good afternoon.
Good afternoon. By profession, I am microbiologist. Actually, we also learn from mistakes also. Now, what I have seen from this presentation, the initial fast CSF, we could have done CBNAT or NAT test. So that was missed. So I think that opportunity was lost. So MTB and risk status could be identified. And second point is that it is a meningitis with multiple tuber granuloma. So history of BCG vaccination of this patient was very important also. And thirdly is that meantime in the duration of the course, CSF could be drained and then its CBNAT and culture might also available if it was done. It is only from my end, and others can say anything on that. Thank you.
Thank you so much, sir, for your inputs. Any other? Okay, so now Dr. Saurabh Jain is looking after this case and he has worked up this case in detail. I would like to have your opinion, sir.
Good afternoon, ma'am. Ma'am, actually, we discussed this case with neurologists in our institute as well as the radiologist also. They have mentioned that most probably it is a tuberculosis only, because another thing that Alkesh sir told, it could have been grown so far if it is malignancy or another thing. The another differential that radiologists were concerned is about the fungal infection, but the patient's presentation was not consistent with the fungal infection in the brain, because the fungal are usually invasive and it has created a lot of havoc till now. So they were like, it could be, most probably it could be tuberculoma. And they have suggested to go for a MR spectroscopy so that we can further know what is in the real time now. The concern is that should we treat this patient with ATT now or not, because she has taken ATT for a long time till now, whatever those or fallacies we have seen the case. But the concern is that what should be done now at present for this case, basically.
Yes, sir. The discussion is still open to the house. Any other suggestions, any comments from the house? You can. It seems everybody's silent about this case because it's been complicated. Yes, Dr. Radha. Ma'am, your voice is not clear. So I'll move to our national expert, Dr. Salil Bhargav, sir. Sir, your comments, please.
Thank you, madam. As you rightly said, everybody is silent because it's certainly a complicated case. But every case teaches you something. We have been discussing, Dr. Rupak came to Bhopal a few days back, and we have been watching carefully. Extrapulmonary TB is slightly difficult to diagnose, manage, and to understand when resistance is there and when to stop the treatment. So these are all problems which we have seen in this patient, and this happens very frequently because what happens? These patients are going to neurologists directly. Neurologists are not trained for diagnosing drug resistance TB or other things. They go according to their own routine workup as they have done. They have taken CSF, but they miss the opportunity to get CBNAT done in this patient. Otherwise, that would have been the most important point to shift the diagnosis, the treatment workup from that side. Fine. So they started anti-TB drugs. What is happening? The anti-TB drugs, they had their own problems and they were changed according to what they could do. I know starting treatment for a few days and then stopping is not a fair thing. But as I have told that this is not trained, this is not told to the neurologist very frequently what they should do, and they have been handling it. The next point is, it is not the radiological shadows which should govern the treatment part. Continue, follow, staying drug resistance. I've been following such type of CNS TB for last so many years, but I take help of our neurologist friend and I talk to them. And in fact, it needs continuous discussion between neurologist and pulmonologist who handle TB patients. So in this patient, multiple times, as Alkesh has rightly said, mistakes have been done. But nobody does mistakes knowingly. It has happened because of the present scenario or the present positions, whatever it may be. So the problem is with the patient and with us, what to do now. What I think, as rightly said, we should wait till we prove that there is some visibility of mycobacteria and culture reports if they are available. Because depending on radiological reports, you cannot restart, you cannot change the medicines. It is very difficult, particularly in neurological TB. I followed many cases for years together. The shadows, they persist together for years together, 2, 3 years, 4 years. And you cannot change the medicines depending on their positions. If they increase in size, sometimes they increase in size. Even then, you have to wait for some times and you have to continue with the medications which are suiting to the patients with which the clinical symptoms have improved. So this is the way usually we follow. But this patient has multiple issues. We should wait. Steroids have been given, anti-epileptics have been given. So symptomatically, the patient has been covered well. As far as anti-TB drugs are concerned, if we see that radiological deterioration is there, certainly we should think of some other possibility, as you have been rightly saying since early discussions in this case. Is there any other probabilities? Although Dr. Saurabh has discussed with neurologists, but still it cannot be closed as far as diagnosis is concerned. If the patient is not improving with anti-TB drugs, we should always think of resistance is one, and the differential diagnosis should also be kept in mind. This is all from my end, madam.
Thank you so much, sir, for your valuable inputs. Like you rightly said, yes, we'll keep tuberculosis as one of the diagnoses, the first differential. But the second differential of fungal infection, of protozoal infection, of bacterial infection, which causes granulomatous lesions and malignancy, should also be kept in mind while working up this patient further. So the house is totally silent today. So since so many eco clinics I'm attending and we're part of this session, I've never seen such a silent house. So this is for the first time. I would like to ask Dr. Singla, sir, to give his opinion on this case. Sir, please.
Dr. Meena, I just want to ask one question.
Yes, sir.
Hello. Yeah, Dr. Meena.
Yes, sir.
Dr. Meena.
Yes.
Yeah, I just want one question.
Yes.
In this case, I'm Dr. Anand Agarwal.
Yes, sir.
is there any role? Yeah, CSF examination. We can conduct a CSF examination and send for whole genome sequencing or targeted genome sequencing. Will it be helpful? And TDM, uh, therapeutic drug measurement, that can also be helpful in this case because patients having the gastritis as well as vomiting complaints. So that can also be done. Uh, is there any comment on
Yes,
it?
Dr. Anand, I think Dr. Singla sir will be covering up on these points, TDM and mother trace monitoring plus gene sequencing also. So let's hear to Dr. Singla sir first, and then we'll come up again with more discussion.
Sure.
Yeah.
Singla, your voice is not audible.
Sorry, I'll speak again. It was off. I'll speak again. You see, as we have heard all the case presentation and the opinion of senior faculty like Dr. Alkesh, Dr. Saleen and others, this is not a simple case. 25-year-old female and having this kind of presentation, they initially treated by mainly by the urologist, and I don't know how often they consulted the chest physician for this. And we always manage the cases of CNS TB together, along with neurologists as well as the chest physicians. What neurologists know about the CNS TB, we may not be knowing. What we know about the drugs, their dosages, and how to rule in or rule out the drug resistance, maybe we are better off in that front. But ideally, both of us have to work together. Like in case, if you just summarize this case, so this was a 25-year-old female who was diagnosed at CNS TB way back in May 2020. But if you see, even that time, the CSF was not very much suggestive of this. The cells were normal, protein was not raised, and the CVNet had not been set. Anyway, there were CNS findings on MRI, which most likely were likely to be having TB. So she was diagnosed as CNS TB and was put on the first line drugs. That is INH, rifampicin, ethambutol, palicinomide. The FDC was given to this. And since then, from May 20 to 2024, today, April, she has been on these drugs, except when she had twice hepatitis when the drugs were modified for a month. And primarily, she has been on these 4 drugs. There was 9 months break in 23. She received linezolid for 5 months in 2020 and moxifloxacin from July 23 when the treatment was started again till date. She had apparent treatment success in November 22 as the symptoms had resolved, but we are not sure what was the criteria for declaring as treatment success. But the treatment was stopped in November 22. Then in July 23, based on the radiological deterioration, or at least persistence of shadows in the brain, with mild increase in the shadows without any symptoms, patient was put on the anti-TB medication again. So now, despite this ATT of the first-line drugs, that is INH, rifampicin, ethambutol, palicinomide, plus moxifloxacin, since July 23, that is almost 9 months, patient is showing no improvement as per the repeat MRI, which has been done in January 24 and April 24. And our worthy neurologist, based on the entire spectrum, they went ahead to rule out, I think, the reason for non-response and to see whether it is drug resistant. They've done the brain biopsy in 24, which is showing poorly defined granuloma. The CBNet they had done for this biopsy, wherein the MTP was not detected, and the culture is awaited. In the presentation, we are not sure, as somebody suggested also, Dr. Agarwal, I think, whether the CSF was also done during this period. And if CSF had been done, it could have been subjected to all microbiological tests, genotypic as well as phenotypic, including the whole genome sequence, which could have helped to know that whether a patient is sensitive or resistant. And even now it can be done. You see, it's never too late. In this case, even now the CSF can be examined and we can have answers to some of these questions. Now, since in April 24, the brain biopsy, the CBNet was not detected, I have my own doubts whether culture will be born. So in case we keep on waiting for the culture, and you know, the laboratories, they wait for 6 to 8 weeks, rather 8 weeks, before they declare that the culture is negative. So it will not be, personally, I feel, may not be very wise idea to wait for the culture report. Rather, we should do the CSF examination and go ahead with the all microbiological tests, biochemical tests to really see what is happening to the patient. Next. Again, we know in this case the microbiological diagnosis of CNS-TB was never made. Even when we had the opportunity, we did not have any result which shows microbiologically it is CNS-TB. But again, as has been discussed also, the possibility of non-TB diagnosis is unlikely. Now, if you look at the X-ray which was discussed also in April 20, it had shown paratracheal lipid. And if at that time again we had an opportunity to do the EBUS at that time, which may have given us the microbiological information, but we missed the opportunity at that time also. Right? Now, the reasons for, first of all, I would like to say that because of the persistence of lesions in the brain or MRI, if at all mild deterioration in the MRI of January 24 and April 24, we can attribute this non-response due to first non-compliance of treatment, which has not been mentioned whether patient was compliant to the treatment or not. I have another concern is about the improper dosages. If you look at the weight, in May 20, he started with 45 kg and currently 3 tablets of 4 FBCs were given, as shown in the history. January 21, she was weighing 61 kg. How many tablets were given? At least I could not see in the presentation. Then July 23, she was weighing 89 kg. And now the 6 tablets of FBC were given. So between May 20 and July 23, how much ADT she received? Sorry, we have doubts. And most probably she must have been on inadequate dosages of NDTB medication. Another possibility of this, I can say the lack of response, or at least delayed response, could have been the low blood levels. So in case we have that thing in mind, we should do the TDM. Next. And now TDM, we can have two findings. One is the levels are low. The second is the levels are down. Before that, before we react that no, we need to treat, you see the 25-year-old young girl showing persistence of lesions, although she has no symptoms. And she has been on anticonvulsive therapy throughout, although the dosage was not correct, rather she was overdosed. But she has been on anticonvulsive therapy. So these cases, you may not have symptoms of the culture in CNS. So I feel that in this case, opting not to treat her, waiting for the culture, may be little not a very good idea because culture we are expecting it to be done. Excuse me. So I feel that she should be declared as sort of clinical failure and put on the longer oral regimen. Now, if the plasma levels of antidiuretic medications are low, then the regimen for this case, which can be considered, will be bedaquiline, linezolid, clofazimine, injection amikacin, delaminate, ethionamide, and high dose R. Why? You see, she took linezolid only for about 5 months from July 20 to November 20. So it is likely that it could still be effective now. Moxifloxacin she had been using for last more than 1 year. So we believe it may not be effective and it needs to be replaced by delamine. Cycloserine definitely has good CNS penetration, but it's also known to have CNS toxicity and convulsions. And in this case, patient has had convulsions multiple times and she is on anticonvulsant therapy. So if possible, we need to avoid cycloserine, although it has a good CNS penetration. Ethonamide is one of the best drugs for CNS infections by TB. A very good CNS penetration. Ethonamide you can add. Rifampicin should be avoided in this case for two reasons. One is we are recommending to treat with bedaquiline. And bedaquiline and rifampicin have drug interaction. And also rifampicin has poor penetration to the CSF. So for these reasons, I'm suggesting this regimen. Now, on the other hand, if you have plasma levels next, if you have plasma levels of ATD, they are within normal range. Then, in that case, we need not rather give the high dose iron. We shift to the longer role regimen, consisting of bedaquiline, linezolid, clofazimine injection, vicacin, delamanid, and ethionamide. Of course, my concerns will be the CNS penetration of bedaquiline, delamanid, and clofazimine. They are not very low. But now, in this case, I don't think we have much of choice. All the injectables, including the vicacin, which will have, excuse me, they have poor CNS penetration. Even in inflamed meninges, the CNS penetration is not very good. So I feel she should be managed like this, and I'm open to the suggestions from the house. Thank you.
Thank you, sir. Thank you, sir, for such a detailed description of patient. I covered almost every point from the case. So, on that reminds me that Dr. Saurabh, have you repeated the chest X-ray of this patient? Like we have mentioned in the beginning, the patient had some mediastinal lymph node or enlargement. But have you repeated the chest X-ray of the patient when she visited you? Dr. Saurabh, Dr. Khetal?
She visited us recently. The chest X-ray was normal, and she has no respiratory complaint for now.
Okay, sir. Thank you. Thank you so much for that. The house is again open for the questions and discussions. Please come up.
Dr. Rupak,
Yes, Doctor.
I have one question. Yeah, actually, in the modified unit, we are adding the high dose of isoniazid because it has good penetration in the CNS. Why don't we add the pyrazinamide? Because there is no resistance pattern. Pyrazinamide also has good penetration, 80 to 90% in the CNS. If we are adding some other drugs which are less penetrating like bedaquiline, why don't we add a pyrazinamide in a filling regime? Because we don't have anything in the hand. This is the last resort, I think.
Yes, I think very good question. See, why I have not added pyrazinamide is, in case you see this regimen, it has already has 7 drugs, right? And if the levels are low, INH we can give in the INH we can give in high dosages. It is well studied that high dose INH may be effective and the normal dose INH may not be effective. We do not have the mutation pattern of presence of CATG mutation. Had that been there, we'll say one high dose INH is not there. And if you see pyrazinamide, this person has received right from the beginning. So almost 4 years, patient has received the pyrazinamide containing regimen. So I feel that continuing it now may not be of much use. Regarding bedaquiline, you see, we may not say it has poor penetration. Very, very limited reports are there. It is lipophilic drug. So even one is the CSF concentration, one is the concentration in the brain tissue. So some of the reports which I have discussed about the bedaquiline, they say it could have a good CNS tissue concentration. So it is too early to say that bedaquiline is not a very good drug for sale. The data is good. That's where we are. Thank you.
Thank you, sir, for your inputs. So, there's one more query which is going on. Like, if the patient come, you've already covered that, though. If the patient's reports comes out to be sensitive to all the first-line ATT, should we should also again then switch to the MDR regimen, or we can still think of giving first-line ATT?
Yes, regarding this, whenever we give a regimen to a patient in the right dosages and patient does not respond in 6 to 8 months, even if it is sensitive, that means patient is not going to respond to the current regimen. We should declare the patient as at least clinical failure and shift to the drugs other than the existing drugs the patient is taking. That's the general rule. So if this new regimen may consist of, because once you have used all the first line drugs, it may consist of the second line. And this patient has received for 4 years. Unfortunately, most probably the dosages were not correct. So I think keeping that in mind, I would like to shift her to the second line.
Thank you, sir. Dr. M.M. Puri has one question. Sir, please.
Thank you, Dr. Saroj. In this case, my query is it a active tuberculosis? Because I have seen that in this case, the patient has gained weight from 45 kilogram to 89 kilogram. Chest X-ray now is normal, no complaints, no fever. Now the neurological deficiencies there, whatever the seizures are there, are like the sequelae of the tuberculosis? Should we treat this patient with anti-tuberculosis treatment at present, or we should give only the neurological treatment for the neurological problem? That is my question.
So the weight gain in this case, patient, like if I say, can be due to different and multiple doses of steroids the patient has
Weight
taken.
gain is from 45 kilogram to 89. So
Yes.
89 weight. If it is a MDR tuberculosis, I will not expect that the patient will have gained such weight. The patient lungs will remain spared for 4 years. The MDR or the XDR TB is there. To me, the TB has been treated and adequately or over treated. Now the problem is with the neurological problem is there, and that should be treated by the neurologist. That is my opinion.
Okay, sir. Thank
You
you.
see, Dr. Puri, I agree with you. Rather, I will say it is an abnormal weight gain. We have to rule out the possibility of hypothyroidism. Because 45 to 89, it is too much of gain in the weight, whether patient is having TB or not. Even in TB with steroids, this much of weight gain is not acceptable. We have to look for the reason why a patient is having this abnormal weight. Now, secondly, coming to this, you see, she is a young girl. There has never been improvement in the CNS whenever MRI has been done. We are expecting inadequate dosages as per weight for this patient. So, excuse me, difficult to decide in this case whether this is a sequelae or not. And even sequelae, the lesions should have been same or improved, which has not been done. So, to give this benefit of doubt in a young girl like this, I would like to treat her. And if I'd like to treat her, then the first line drugs will definitely not be my choice. I'd like to go for the second line drugs, depending on the plasma levels of the drug. Thank you.
Thank you, sir.
Thank you.
So, as there's no more questions either in the chat box and the queries by the house, so I would like to call Dr. Ashok Bhardwaj, sir, to. Yes, sir.
Actually, the problem is there is no, from the beginning, there is no bacteriological confirmation of this case. And one thing that some respected participant has mentioned, that gene sequencing, but that is not possible until you have the pure culture. Because from gene sequencing also, it needs pure culture of the bacteria. And biopsy I think it will come negative, because in closed granuloma, if there is any organism that is already dormant stage or dead, so in midget culture, I think there would be no positive response from the midget culture. Thank you.
Thank you so much, sir, for your input. Any more questions? Okay, so now I'll call Dr. Ashok Bhardwaj, sir, for his closing remarks. Sir, please.
उसके बोल दूं मैं, है ना? So thank you, madam. Thank you. So I could not listen to whole discussion. So but I wish to thank Dr. Rupak Singla. I think Dr. Neeta is not here today. So
Yes, sir, she is not there.
she is not here. So thank you very much. It was a nice discussion. So from Gandhi Medical College, Bhopal, yes, the person sitting in the chair of the Dean Principal, Dr. Salil Bhargava. He is doing excellent job, and he is doing one activity, that is SETI, where they have trained many DTOs in the country. So thank you, Dr. Singla. Thank you for giving me a chance for coming in the discussion and giving the concluding remarks. So thank you very much.
Thank you, sir.
Thank you so much, sir. So with this, we would like to close the session for today's session. And there is a feedback link shared in the chat box. Please kindly give your valuable feedbacks, which will help us to improve us further. And it is very important. Thank you all. Thank you, everyone. Thank you.